already 9 cm. Yeah. So now they are doing it for 10. I think either the work must be, because I couldn't attend their last the GA meeting, though I am a member. But then the target was to complete it sometime around this time, April or May. So that work will be done. But then Dr. Karan Berry, you were present in all the meetings of our project review and steering committee. So, in fact, CDAC, Pune and Apollo, they are collaborating to develop SNOMED city kind of ref sets. We call, because SNOMED city use करने के लिए you have to develop certain reference sets, and then you need certain toolkits also, because SNOMED city as such is really a black box. If I tell you very bluntly, everybody and anybody cannot use SNOMED city. We need to develop some reference sets, we need to develop some toolkits, and it is hoped that the CDAC Pune, our National Release Center, will be able to develop some ref sets, some toolkits in some areas which can be used. But I totally entirely agree with you that Apollo can use SNOMED city, but there are many other providers who may not be able to use SNOMED city.
Mapping, etc., is the change management.
Agree.
So I think what we just heard was one part of it, where you have a conversion from SNOMED or ICD to SNOMED or vice versa. So that's one part of it. All hospitals who have an HIS, they are working with some coding standards. Now those codes have to be changed to the SNOMED. That change management itself takes time. So that's my little personal experience, which is, so we should not only do the mapping, but we should also do one change management in a hospital to see how much time it takes, because that's the complete implementation. So conversion is not the implementation. Conversion plus change management would be the implementation. Just thought, sorry.
Just to share our experience, SNOMED. Yeah. But again, SNOMED is a very huge terminology, and the entire the entire, like what you capture today for the patient it can be done. So, but again, if you want to really force SNOMED usage, I think we have seen the standard. Last time we participated when there was a session in Delhi. I think what was missing in our view was that next level of adoption where it has to be adopted. Okay, so it's very huge. Even if you say some people use it for lab results, which is because they want to compare the results. Using it for diagnosis is a nightmare, because SNOMED is not a one-to-one to ICD. It can be, because SNOMED goes into multiple levels of details, and again it needs some tools and stuff. I think what would help for us, people like HIS and stuff, is if I think SNOMED is there. I think you need to really granular level to say 1, 2, or 3 as a priority. Like you should start using it, and this is what you should do it. I think that is not. I think was not the interest.
CDAC Pune to organize consultation with clinicians as well as vendors at various locations. They conducted the first consultation in Noida about a month ago. So now they will be conducting the consultations in Pune, in Chennai or Bangalore, wherever I think, and then also in some part in Calcutta also. So they have been asked to basically talk to the developers, talk to the providers, and assess their need, what basically the National Release Center has to do. Because unless they come up with really some reference sets, they come up with some toolkits, individual developers, individual hospitals cannot really do that. And we have also told them that can be done through collaborative efforts. I think, will you like to supplement Professor Sarvadhikari? I think I could not attend the last meeting of the committee, but can you please?
Yeah, no, I think you covered most of the things. As you rightly said, it has to be a gradual approach. One thing is SNOMED CT is, of course it's a controlled medical vocabulary, but then it can be used in different purposes. I mean, the example that the people who come there from training give, it's like a gearbox of the car. So if you put the gearbox on the top of the car, it won't serve any purpose. But if you want to use the gearbox, it has to be connected to the wheels and the steering and everything in a proper way. That means alignment. Now, you need not use the whole of it one single go. So you can use it, you can define your purpose. Why are you going to use it? So if you are looking for diagnosis, as I said, diagnosis if you have to give the outputs in ICD-10 as per the requirements, or it may become ICD-11 because ICD-11 is expected to be ready by the end of this year, and that will be one-to-one mappable with SNOMED City. SNOMED City is being one-to-one mappable with LOINC. So LOINC, SNOMED City, ICD-11, they are all going to be easily transferable from one to the other. But the point is how much you are going to use. You don't have to use the SNOMED City as a whole for everything. Most of the places we don't even have a proper electronic medical record. Forget electronic health record. It's a rudimentary system. The advantage of Greenfield is that you can really pick and choose, do the things you need. When you go to the brownfield, then those legacy systems, those things appear which we really don't have to worry much about at this point of time in our country. So wherever we are starting, you first decide what are the things you really need to document and put it. SNOMED City is so well structured, and I think Dr. Karanveer Singh would be able to actually explain it much more better way because he has lived through it. So it can be used for whichever purpose you need. You decide the purpose, use it for that. Start small, scale up gradually, I think, currently.
I just want to know whether the EHR available in your cloud can be used in other hospitals if the patient wants a second consultation in other hospitals.
Karanveer, what's our experience with that?
At this stage, we are sharing some basic patient data across the Apollo hospitals, but not outside Apollo hospitals. But then again, once NEHA comes in and the mandates come, then obviously we will be working on that.
So you have started using the Aadhaar number as a unique identity of the patient?
No, we are just recording the Aadhaar number in one of the fields, but that's not a unique ID.
So I think we should start using the Aadhaar number as the unique
But the problem is if you have a patient who doesn't have an Aadhaar number who's come for treatment today,
We can
what
have
do I
the
use?
second field for mobile number and other
No,
things.
but then if you have a unique identification number, then it has to cover 100%. You cannot say I'm using unique identification number for 70% of the patients, but for remaining 30 I'm going to use a different one.
But
So
once NEHA comes in picture,
no, I think it's
then
not
it
NEHA.
will be a
It's-
two.
No, I don't think it's NEHA. It's the Aadhaar card reaching 100%. As soon as it comes 100%, everyone will want to move on to that.
No, but it will never reach 100%.
A case where you have an accident, right? Somebody spoke about a case. So somebody's had an accident, he's brought into an emergency, so you can't stop his treatment because you don't have his Aadhaar number, right? So, but you have to enter his data. So typically hospitals, and we had debated this when we implemented EHI, was that we will give a hospital ID, but we will also create a field for UID. So when you merge the data with HIE, which is the Health Information Exchange, you merge it on the basis of UID, but at least internally hospital need to have the two fields, and that's the reason why, which Karan's also explaining. You need to have an internal number plus UID both actually in the hospital, because you make it you can't send the emergency
But
case
in
back.
the case of accident, the patient will not be able to tell the
हाँ तभी इसलिए
unique
वो
ID, but,
लेकिन उसका
but,
ID
but
बनाना
from the
पड़ता है.
biometric,
Biometric
one
भी-
can take the biometric of the
हाथ पे चोट लग
patient.
सकती है ना, नहीं वो कर सकते ना आपको, you have to treat the patient then.
That's true, but in general, if the data has to be shared for the normal patient, it will be.
No, there is another
See,
scenario.
the beauty of a
So-
debate on healthcare is you can debate till death. And there are so many solutions. And I love the discussions because that's the uniqueness you bring to this kind of forum. Firstly, I think need to thank Anupam for standing so long, and enlightening us. This is an interesting, enlightening discussion. We'll move to the next speaker, Chandrasen Srivastava from Ministry of Health, who's going to shed light on the e-health programs in the country. And after that, we have open discussion. So, not free for all, but I'm sure we can freely share our thoughts.
Good afternoon, everyone. In earlier sessions, we heard